Two, one. We are live now.
Good morning, everybody. On behalf of IPCA, I would like to thank all the esteemed panelists as well as the audience for joining us today. IPCA has always been in the forefront in disseminating the rheumatology awareness. As an endeavor in this direction, today we have gathered for an online webinar. And I once again thank the panelists for consenting to be part of this particular webinar. Before I start with the webinar, I would have like to make a small announcement. This is the Indian Rheumatology Association has initiated a series of online webinars on the weekend of every month. For the month of September, the IRA webinar is scheduled on the 26th of September, and it highlights the update on spondyloarthritis. I request all the attendees to please join us on the 26th of September. The details will be sent shortly. Moving ahead with today's webinar, as all of you are aware that for the last 2 to 3 decades, there has been a lot of advancement in the pathophysiology of rheumatoid arthritis, which has led to quite a lot of updates in the management of rheumatoid arthritis. As in this direction, today we are going to discuss disease-modifying drug, that is Iguratimod, in the management of rheumatoid arthritis. To take us through this, we have a panel of speakers, and moderating today's session will be Dr. Sapan Pandya. Though Dr. Sapan Pandya does not need an introduction, it is my privilege and honor to introduce Dr. Sapan Pandya. Dr. Sapan Pandya, the astute rheumatologist, has been the ex-alumni of the SGPGI. He is currently working as a consultant rheumatologist in Ahmedabad in the Vedanta Institute of Health Sciences. He is the honorary rheumatologist in the VS Hospital and is also in charge of training postgraduate MD students in rheumatology. His areas of interest have been primary Sjogren's syndromes, chikungunya arthropathy, and palindromic rheumatism. He is the secretary of the Indian Rheumatology Association, and I thank him for being part of this webinar. And I would request to kindly initiate today's proceeding by introducing all the panelists and taking over the session. Sir, can you please start with today's session?
Thank you, Padmaja, for the kind introduction. And thank you, IPCA, for the initiative. It's so nice to see all of you during this COVID pandemic. So we have this session on Iguratimod, a drug which has been off and on there for quite some time, actually. But recently, there's been an upsurge and people are wanting to use it. So we'll have a very although this is a formal session, I suggest that we try to make it as informal as possible and that you put in all your questions from the word go. Please do keep sending your questions so that we'll assimilate those and let it be a free and fair. You will not have such good panelists like Professor Malavia sir and even people like Shanoy and Sharma and Shashank who have used this drug. So please feel free to ask questions, especially on their experience of the use of these drugs. And let us dissect Iguratimod thoroughly today so that we know when and how to use it. With that, I'll now introduce the first speaker, Dr. Shashank Akerkar. And I was just talking to Professor Malavia informally before a couple of minutes that he's our Faf du Plessis, if you have seen the match yesterday. And he's been a person with full stamina running around in Mumbai, a city which needs that kind of stamina. And so he will be talking on, Shashank is attached to the Fortis Hospital, Mulund, and he also has his own clinic, all of you know, in Mumbai. He's a very busy rheumatologist. He has used this drug himself, so it's always best to ask the person who has used the drug. He'll be talking to us on the mechanistic overview, the molecular overview of the mechanism of action of Iguratimod. So again, with a reminder that please keep posing your questions. I'll be looking at them and we'll have the question answer session at the end of all the 4 talks, but please start sending your questions. With that, I would now ask Shashank to take over and talk on the mechanism of action of Iguratimod. Thank you.
Thank you, sir. Good morning, everybody. Great to be here with all of you digitally today. Is my screen visible?
Yes, it is.
So talking about starting basically with what we have achieved in rheumatoid arthritis and what is the place for Iguratimod before really going into the mechanism of action of Iguratimod. As far as rheumatoid arthritis is concerned, we have come a long way, starting from a disease wherein there was no treatment to a stage wherein we had symptomatic treatment to a stage now wherein we are looking at remission in most of our patients, if not remission, low disease activity in most of our patients. To begin with was the era of NSAIDs and steroids. Then with the introduction of methotrexate came the era of DMARDs, followed by the introduction in 2000 of biologics. At the same time, we had a lot of strategies to achieve low disease activity or remission, the COBRA study, TICORA study, getting into place the intensive management and the treat to target strategy. All this taking us towards the target of remission in each and every patient of ours, if not remission, low disease activity. In spite of all this, what are the gaps in rheumatoid arthritis therapy today? Even as of now, methotrexate remains the anchor drug in most of our patients. If the patient is intolerant to methotrexate or has inadequate response to methotrexate, we get out of that comfort zone in our patients. We have biologics which can take care of the rheumatoid arthritis if this situation arises. We also have tocilizumab, we have targeted synthetic DMARDs which can be used as monotherapy. But particularly in our setting, cost and affordability becomes an important issue. So this is where not many of our patients can afford biologics. And this is where the place of this new molecule comes, Iguratimod. Let's have a look at how this molecule works. It is a small molecule which has anti-inflammatory and immunomodulatory actions and has been developed as a disease-modifying anti-rheumatic drug. It was discovered by Toyoma Chemicals Company in the mid-1980s and later jointly developed by Japan by Isai and Toyoma Chemical. To begin with, it was developed as a novel NSAID, but later on it was seen that it reduces the level of interleukin-6, and then it became being investigated for a prospective DMARD effect. As I said, it was being introduced. To begin with, it was thought to be a NSAID. It is chemically related to NSAIDs, nimesulide and flocculide. Over a period of time, as far as the approvals in rheumatoid arthritis are concerned, it was first approved by the China FDA in 2011, subsequently by the Japan Pharmaceutical and Medical Devices Agency in 2012, and it has been approved by the DCGI in 2019, Feb of 2019. How does it really act? Before really getting into action of Iguratimod, let's have a look at what NF-kappa B system is all about. NF-kappa B is a short name for nuclear factor kappa light chain enhancer of activated B cells. It is not a single protein, but a family of inducible transcription factors that play an important role in almost all the mammalian cells. It controls DNA transcription, cytokine production, cell survival, and other important cell events, especially plays a key role in regulating immune response to infections and also in autoimmunity. It is present in almost all the mammalian cells, almost all the immune cells that are involved in infection as well as autoimmunity. As you know, the rheumatoid arthritis synovium is infiltrated by immune cells, macrophages, T cells, also to some extent B cells. Various stimuli trigger the macrophages that puts the NK alpha beta system into action. This results in production of multiple cytokines, including TNF alpha, interleukin 6, the metalloproteinases. The TNF alpha further stimulates the cell, continuing this auto system of autoinflammation. It also acts on the other cells, the FLSs, and further continues this chain reaction of inflammation. If we look at this signaling pathway in detail, the NF-kappa B system, multiple stimuli, including cytokines, and various other stressors for the cell act through various receptors. Once the receptor is stimulated, as you can see intracellularly, the active component of this system is RELA and P50, as you can see here. This is always present in the cytoplasm. To keep it in the inactive phase, IKB inhibitor is always associated with it, attached to it, so that it is present in the cytoplasm but remains in an inactive phase. Once the receptors are stimulated, IK kinase enzyme is activated, which phosphorylates the inhibitor. Once the inhibitor is phosphorylated, it detaches from the RELA and P50. That is how the REL P50 now become active, move into the nucleus, and along with other co-activators, then start the further process of mRNA and translation into multiple proteins. What this pathway generates is multiple cytokines, including TNF-alpha, interleukin-6, various chemokines, and matrix metalloproteinases. And this is what is responsible for the inflammatory response in arthritis like rheumatoid arthritis. This pathway is responsible for multiple pro-inflammatory cytokines that we already saw, and also helps in antigen presentation of multiple antigens. At the same time, it has also been seen to be associated with destructive processes by the production of matrix metalloproteinases, affects chondrocyte differentiation and repair of damaged cells, as well as osteoclast generation and maturation. So where does Iguratimod act? If you look at this system, Iguratimod prevents activation of the entire system, and this is how it blocks the production of the cytokines, the resultant cytokines that are generated, the TNF-alpha, interleukin-6, and the further chemokines. So, though the common perception that Iguratimod probably has only NSAID effect, it has immunomodulatory and a potent anti-inflammatory action as well. As you have already seen, it inhibits the activation of the system, thus reducing the production of cytokines, TNF-alpha, interleukin-6, and the other cytokines, the various chemokines that are produced. Apart from that, it has an immunomodulatory action as well. It inhibits the T cell differentiation, decreases the Th1, Th17 cells that are responsible for the inflammatory response. Not just the T cells, but it has also been shown to inhibit the immunoglobulin production by B cells without affecting their propagation, and thus reduces the production of IgG, IgM, and IgA. There have been multiple studies that have looked at this, and what has been shown is, as far as T cells are concerned, the Th1, Th17 is deregulated, and T regulatory cells are upregulated while on therapy with Iguratimod. This is one of the studies by Zhu Wei et al., which showed that the Th1, Th17 response is downregulated by Iguratimod, and the T regulatory response is upregulated. Apart from its immunomodulatory effects, which obviously have a direct effect in rheumatoid arthritis, it has an additional anabolic effect on the bone metabolism as well by inhibiting osteoclastogenesis and stimulating the osteoblastic differentiation. So, all in all, if we have to summarize, it has an immunomodulatory effect, an anti-inflammatory effect, and some anabolic effect on the bone metabolism as well. Whether this translates into clinical efficacy in rheumatoid arthritis patient, I think the next speaker would be taking care of that. Thank you very much.
Thank you. Thank you, Shashank, for the excellent summary. So basically, NF-kappa B is one of our central transcription factors, and once you target that, there is this pleiotropic effect that we saw over so many cells and so many different systems which affect the inflammatory illnesses. So as Shashank said, theoretically, it seems to be fine. Now what we need to know is whether this really works in vivo also in patients. And for that, we have Dr. Padmanabhan Shenoy from Kerala, Kochi. He has his own center there. He also is a teacher for DNB students now. His center has been approved for DNB. And he also happens to be the treasurer of the Indian Rheumatology Association. And he has a personal experience of the use of this drug. So I think he will share his clinical experience of the drug in rheumatoid arthritis. So Shenoy, please. You're not audible, Shenoy.
Am I audible now?
Yeah, please. Share the screen, yeah.
Thank you, Sapan Boss, for the kind words, and I would like to thank IPCA for giving the opportunity and conducting this webinar. And so I will be speaking on what is the efficacy and safety of Iguratimod in rheumatoid arthritis. So as Dr. Akirkar told, Iguratimod, if you look at, initially it was an NSAID, then there has been a lot of basic studies which say that it is effective as an immunomodulator too. But it has been in the field for almost 14-15 years. The first paper, which was published way back in 2007 in Modern Rheumatology, a Japanese study. This was a randomized controlled trial. They include 376 patients and randomized them into 3 groups. One group was given sulfasalazine of 1 gram, second group was given Iguratimod of 50 milligram, and third group was given placebo. So if you look at this, and the patients' numbers were 376, and at baseline, all the groups were comparable. And they looked at the ACR20 response, and as you can see here, both Iguratimod and sulfasalazine had around ACR20 of 55 to 60%, while placebo had 17% ACR20 response. So there is no need to say that Iguratimod and sulfasalazine both were superior to placebo, but sulfasalazine and Iguratimod were comparable to each other. So you can see the response. From week 28, around 65 to 70% of the patients, both in sulfasalazine group and Iguratimod group, had ACR20 response, though they were comparable. But what is the problem? The problem is that lower dose of sulfasalazine, that is 1 gram of sulfasalazine, was compared to the maximum dose, that is 50 milligram of Iguratimod. So that is brings in a bias there. Second paper, which was a major randomized controlled trial, again from Japan, was published in 2013 in Modern Rheumatology. About Iguratimod, one thing we have to be very clear is that most of the data is from Japan and China. And that's maybe the reason that other countries have not taken it up. We are taking so much about neoptism and promoting their own baby. So America and Europe has not really taken up this molecule. Unlike tocilizumab, which was taken up by Roche and promoted in other countries, Iguratimod was really not taken up by other countries. So the number of trials in other populations and other geographical areas are much less. Whether this is because of a particular reason, we don't know. But we have to be aware that most of the data is only from Japan and China. And this second study, which was again a randomized controlled trial, which was published in Modern Rheumatology in 2013, what did they do? They took up methotrexate inadequate responders. In Japan, we know the dose permitted of methotrexate is much less than India and or other countries. So in all of us use 20 milligram or 25 milligram or even 30 milligram. But in Japan, because the people are very sensitive to this drug because of genetic factors and their low BMI, the dose of methotrexate which is allowed is 8 to 10 milligram per week. So they took patients who were on methotrexate or 8 milligram per week and had a mild to moderate disease activity and randomized them into 2 groups. The first group was given Iguratimod and the second group was given placebo. So at 24 weeks was the primary outcome which was measured. You can see here that these patients, most of them had comparable data at the baseline characteristics. There were around 240 patients who were 164 of whom got Iguratimod and 88 of them got placebo. This is ACR20 response. As you can see from the chart, at week 24, 40% of the placebo group and around 65 to 70% of the Igurati group had ACR20 response. ACR20 response of 70% at 6 months is a reasonably good. So this is a study shows that definitely Iguratimod is superior to placebo in methotrexate inadequate responders. You can see here, what does this show? This shows Iguratimod plus methotrexate group. This chart shows placebo plus methotrexate. You can see here at the beginning, around 40% of the patients had in the Iguratimod group had high disease activity, which came down to 10% at the end of 6 months. While you can see here, 30% of the patients achieved remission and 45% of the patients achieved low disease activity. While in placebo arm, these charts are much lower, or these numbers are much lower. What does this indicate? In significant proportion of patients, Iguratimod is able to achieve remission and low disease activity when used in methotrexate inactivity responders as an add-on therapy. So in this study, they have added on Iguratimod on top of methotrexate. And what was the major side effect? There was not, it was almost comparable, except there was slightly higher percentage of patients who had SGOT elevation. Around 10% of them had, in the Iguratimod methotrexate group, had higher liver function test, although it was not statistically significant. Then they went on to analyze the open label data. After what happened after 24 weeks is that those patients who were on placebo were switched over to Iguratimod. The group which got Iguratimod plus methotrexate were continued Iguratimod plus methotrexate, and those who were on placebo were given an option to be added on Iguratimod. So out of 88 patients, 68 patients got additional Iguratimod. And this was published in Arthritis Modern Rheumatology again 2013. As you can see here, when treated with Iguratimod, what happened? 72% of the patients in the placebo arm also picked up later. So what does it indicate? Even if you introduce Iguratimod later, around 2 to 3 weeks or 4 weeks later, they also pick up. And at the end of 24 weeks, that is 6 months, ACR 20, ACR 50, and ACR 70 both are become comparable. This indicates two things. One, Iguratimod, after attaining good control over disease activity, it is maintained over time. The week 52 data in both the groups, as you can see here, is around 72% ACR 20, 50% ACR 50, and 20% of ACR 70, which is achieved with, this is the type of response achieved with most of the disease modifying anti-rheumatoid drugs. And again, the major side effect was LFT derangement, around 15 to 20%. This was the another study which was published in 2009 in Arthritis and Rheumatism, that is Arthritis Care and Research, which is an ACR journal, where this study was from China. They randomized the patients into 3 groups. The first group was given methotrexate 15 milligram. Second group was given Iguratimod 25 milligram for 4 weeks and hiked up to 50 milligram. And third group was given 50 milligram of Iguratimod for 24 weeks. There were around 480, around 500 patients randomized into 3 groups, and at baseline, all of them were comparable. As we can see here, the ACR 20 response, 50 response, and 70 response were comparable, around 50 to 60% in all the groups. ACR 20 response, around 30 to 40% of ACR 50 response, and 15 to 20% of ACR 70 response. So all the 3 groups were comparable, although the group 1 was slightly inferior to methotrexate group and Iguratimod 50 milligram group. The reasons are not very clear. So what does it say? This study concluded that telling that the Iguratimod is almost equivalent to methotrexate in the treatment of rheumatoid arthritis. Then came the real world data, again from mainly Japanese data again. What they do, they took patients, 177 patients, most of them were on methotrexate, some were not on methotrexate, and it was a retrospective analysis of their own clinic data. So 177 patients, what did it see? Those patients who were on methotrexate, you can see here, this is delta DAS. Delta DAS means how much DAS has improved. In the patients who were not on methotrexate, there was less improvement when compared to those patients who were on methotrexate plus Iguratimod. So methotrexate plus Iguratimod had a better efficacy when compared with those patients who were not on methotrexate. So always it is better to use as a combination therapy. And they showed that what are the predictors of response to Iguratimod. There are 3 predictors. One, methotrexate therapy along with Iguratimod. Second, it is more effective in elderly patients. And third, in male patients. We don't know why, but this is what they have told. But it's a very small data, only in 170 patients, that to retrospective analysis. So we have to be aware of these fallacies before interpreting this data. And last week, a couple of weeks earlier, when Biju told me you wanted to conduct a this kind of webinar, we thought we will analyze our own data. So we had around 240 patients who were treated with Iguratimod till date, higher than the previous retrospective study. So we have taken data from December 2019 to May 2020, and we had 184 patients during that period, and the mean age was 54 years, and the patients had 8 years of disease at the time of inclusion. Majority of were seropositive, 80% were seropositive, and DAS28 ESR at baseline was 3.9. Although 3.9 will seem pretty not very high, but look at the DMRs they have been exposed. 75% of them were on methotrexate, and 63% on sulfasalazine, 50% on leflunomide, and 76% of them were on steroids, and 60% had experienced biologicals in the past. So these were almost patients who were really difficult to treat, because we have tried everything else and they are still having a mild to moderate disease activity despite all this. They were every molecule, new molecule comes with be it tofacitinib, be it etanercept, whichever new molecule comes, those molecules will be tried in patients who are most difficult. So these set of patients, 184 patients, were difficult to control, had difficult to control disease. And then we looked at the 3 months EULAR response. I would just want to tell you that 86 patients were excluded from the analysis, because after March, what happened was, because of the lockdown, we shifted 80% of our practice to teleconsultation, and we didn't have the tender joint count and swollen joint count of these patients, 86 patients. So we excluded this from analysis. But whatever data is available, around 50% responded. 32% had EULAR good response, and 18% had EULAR moderate response. And there was a 50% did not respond. So it is a really not a very bad drug, not an extremely good drug too. But considering that we have tried this in the most difficult patient, even 50% response is something remarkable. And look at the DAS28 ESR. From the baseline, it was 3.8 or 3.9. From that, it came down to 3.1 at 3 months. Our safety data from our cohort, LFTD range was seen in 7 patients, and 3 patients had worsening of anemia. Some series say that there is a prevalence of anemia is slightly higher in these patients, and 1 patient had gastric discomfort. So relatively safe too, despite being used in a combination therapy. What we have done is we have added on Iguratimod to the combination DMRs. Most of the patients were on 2 or 3 DMRs, as you had seen. Some of them were on biologics. On top of that, we have added Iguratimod. So it is relatively safe. So what is the take-home message? Iguratimod is a moderate efficacy, has a moderate efficacy as a disease-modifying anti-rheumatoid drugs. It is relatively safe. But what is the problem? Because of the reasons, as I told you, it is not tried in the major parts of the world. The data is from China and Japan. There are not many well-conducted clinical trials, first point. And second point is, there is not much data on inhibition of structural progression, although there are very small studies showing that there is no progression. And there is one ultrasound study which shows that there is decrease in Doppler signal. There is not much data on the inhibition of structural progression. I think it is an opportunity for Indian rheumatologists to try this out and do randomized controlled trials. Thank you for patient listening.
Excellent, Shenoy. This is what we want, our real world experience and India's own experience. And I think Padmanabhan had shown how we should collate data and keep our own data to look at how this drug is working in our own population. So that helps. Your own data, your center's data definitely helps in for us to use in our patients. So, and as Shenoy pointed out, it seems to be a good drug. There is not much of a problem as regards the safety. You can combine it. It's probably better combining it with other DMARDs. There are some questions coming up, so all of you be ready for the questions. I think that is what is one of the advantages of these webinars, is that the question answer session is not infrequently the best, and we will have a good discussion hopefully at the end. What I will probably be doing is asking questions one after another to each of you, rather than just sticking to your topics, because I think all of you have experience of the usage. I have listed down a few questions, and I hope that more will be there. Please continue questioning. We move on to the next talk now, which is by Dr. Pradeep Sarma, who is from Guwahati. Pradeep is also our ex-alumni from SDPGI, and he did the Indian Rheumatology Association conference 2 years back at Guwahati. All of us remember his hospitality. And he has his own private setup there, and also works in the government medical college there as a rheumatologist. So with that introduction, I think I'll now hand over to Pradeep to speak on the place of Iguratimod in therapy and what do the guidelines say. So Pradeep, please go ahead.
Thank you, sir, for your kind introduction to be this panel of speakers. So I'll just actually, Senna has covered some of the already the trials on a combination of methotrexate with Iguratimod. So and some of the part is covered by Sasank. So my job will be easier. So first, what Sasank has already told, I would like to reiterate. Why we need more DMARDs. We have conventional DMARDs, we have biologicals, we have biosimilars, and we have targeted synthetic DMARDs. Quadranisib, then filgotinib, many more JAK inhibitors are coming. So it's still why we are discussing Iguratimod. So around 15 years back, we entered rheumatology, and since then when we are hearing, what is the modern treatment of rheumatoid arthritis? It is early diagnosis, then always measure disease activity objectively, monitor frequently till we achieve the target, and the target is remission or low disease activity. But what is the real life scenario, which is A from the trials? So this was a real life experience study that did a meta-analysis published last year, 2019. So they excluded the clinical trials. They had studies which were cohort studies mentioning remission, or they have cross-sectional studies, and studies included from USA and different European countries, as well as Latin Americas like Brazil. Then what is the remission rate in the real life scenario? At 3 months, it is only 17%. And at 6 months, not even 1/4 of the patients achieve remission. So though we are talking about target, but still in real life, achieving target is difficult. And what about even if we achieve remission? Do the patients continue their DMARDs? The methotrexate, the main anchor drug in rheumatoid arthritis, if we see, within 1 to 2 years, 10 to 20% of the patients will stop methotrexate because of lack of efficacy or toxicity, whether we use it alone or we use it along with other DMARDs. And around 5 years, again, another 10 to 15% of patients will stop methotrexate because of adverse events, whether we use it alone or use it in combination. Then continuation of biologics. Let us look at TNF inhibitors. At 3 years, half of the patients on TNF will stop it because of inefficacy or adverse event. But most commonly in our country, it is because of the financial reasons, because cost of biologics is still an unmet need. So is Iguratimod an important alternative in this treatment of rheumatoid arthritis? So I have been given the job to review the literature on Iguratimod in methotrexate inadequate responders, that means in combination with methotrexate, and Iguratimod in biologics demand inadequate responders. So this is a busy slide to show the studies we have. And as Senna has mentioned, most of the studies are either from Japan or from China. Then actually, there are only few studies which are randomized double-blind control study. Senna has already discussed this study. So they had total 252 patients, and that is the highest number of patients with combination therapy. Then this was actually a continuation of the first study. Then this was the prospective study. Again, number was small, only 131. So other studies were retrospective studies. So will agree with me that we don't have actually good quality studies with Iguratimod combination therapy. So this study Senna has already discussed. So they had 99 institutes, so looks very good. But if you look at the number of patients, it was 252. So per institute, they didn't even have 3 patients each. So patients were on methotrexate, then the maximum dose was 8 milligrams. Senna has already mentioned that in Japan, the recommended dose, maximum dose of methotrexate at that time was 8 milligrams. Now probably it is 12 milligrams in Japan. But I also want to highlight the important exclusion criteria, along with others like leukopenia or increased acidity or GBT. So body weight less than 40 kg, they excluded these patients. So we should be careful in patients whose body weight is less than 40. And patients in stent progress functional class 4, those patients were also excluded from the studies. So other parts Sana has already discussed, and ACR20 response is much better with Iguratimod combination therapy versus methotrexate alone. Then this low disease activity and remission, this was much more in the combination therapy. So lab data, Iguratimod reduces IgG, IgM, IgA level, which is not seen with methotrexate. Then common adverse events, Sana has already highlighted. I will just mention that nasopharyngitis, then stomatitis, lymphopenia, then increase in beta-2 microglobulin in blood or urine, and decreased iron level. These are some of the side effects with Iguratimod combination therapy. So this was the open label extension of the same study that they continued Iguratimod and methotrexate till 52 weeks, and patients who were only on methotrexate till 24 weeks, the Iguratimod was added, and that was continued with 52. Then patients who were already on Iguratimod and methotrexate, they maintained their ACR20, ACR50, and ACR70 response at 1 year. There was actually increase in response at 52 weeks than at 24 weeks. Patients who were on methotrexate alone, who were there where Iguratimod was added, we can see that the ACR20 response actually more than doubled at week 52. ACR50 response almost tripled at week 52, and ACR70 response, which was 4 times at week 52 than at week 24. Then adverse events, we look at week 24 in the combination therapy versus at week 52, there was actually not much of a difference. So it is well tolerated in the long run. So this is another prospective study. Again, number was small. They compared Iguratimod and methotrexate combination with Iguratimod or methotrexate used alone, and the study was for 6 months. We can see that Iguratimod and methotrexate combination fares better than Iguratimod or methotrexate alone. Whether we look at ACR20 response, that was around 80% actually in the combination group versus around 60% in monotherapy group. ACR50 response almost was 70% in the combination group versus around 40% in the methotrexate Iguratimod group versus 22% in the methotrexate group. So if you see that methotrexate response was low in their study, probably because the dose of methotrexate was low. Then morning stiffness was much better in the combination therapy group. Then adverse events in the combination therapy versus the monotherapy, they looked at infection or increase in ALT. There was not much of a difference in the combination therapy group. So how Iguratimod fares versus leflunomide? There is an animal study. The studies Iguratimod, methotrexate, and leflunomide in collagen-induced mice model. So what we can see that the arthritis score with methotrexate, Iguratimod 30 milligram per kg and Iguratimod 100 milligram per kg is much better than leflunomide or Iguratimod 10 milligram per kg. So methotrexate and Iguratimod are equivalent in reducing the arthritis score, but leflunomide is not that great. And what about the cytokine profiles in these animal studies? We can see that all these drugs, leflunomide, methotrexate, or Iguratimod, reduces TNF alpha, but TNF alpha is reduced much more by methotrexate than other DMARDs. But IFN gamma and IL-6, they are reduced more by methotrexate or Iguratimod. They are less reduced by leflunomide. But what was interesting to see that IL-17 was much more reduced by Iguratimod than by leflunomide or methotrexate. So after seeing this study, I'm actually perplexed why we don't have many more studies in spondyloarthropathy, which is basically an IL-17 mediated disease. We have much more studies in rheumatoid arthritis with Iguratimod, but not that much with in spondyloarthropathies. Then this study, there is a clinical data in the methotrexate and Iguratimod combination versus methotrexate and leflunomide. This was an observational study with only very few number of patients, and they shows that Iguratimod and methotrexate combination is better than methotrexate and leflunomide. So can Iguratimod be combined with 3 or more conventional DMARDs? In 24 patients, they added Iguratimod who were already receiving methotrexate, hydroxychloroquine, and cyclosporine along with prednisolone, and who had this moderate disease activity. So 24 patients they added Iguratimod 50 milligram daily, and consider tender joint was around 8, swollen joint was around 4, then ESR was 32 around, CRP was 15, then DAS20 was 4.85. So in these 24 patients, where Iguratimod was added to 3 conventional DMARDs, methotrexate, hydroxychloroquine, cyclosporine, along with prednisolone, can see that ACR 20 response at 6 months is around 80%. Then ACR 50 response, it is around 65%, and ACR 70 response is around 50%. Does the toxicity increases? There was not much actually. There was no serious adverse events. One patient had mild gastrointestinal symptoms, one had mild edema, and one had mild hypertension. Then the next question comes, can Iguratimod be combined with biologicals? So again, small series, they compare etanercept plus methotrexate with etanercept plus Iguratimod versus Iguratimod alone. We can see that the response of Iguratimod plus methotrexate and etanercept plus methotrexate and etanercept plus Iguratimod is almost similar, and adverse events are again similar. It is much less with monotherapy, but Iguratimod and etanercept and Iguratimod and methotrexate, the adverse events were similar. There was one retrospective report with 31 patients. So patients on tocilizumab, they were not doing well. Tocilizumab monotherapy and Iguratimod was added. Then at 6 months, 64% had moderate response and 50% had ACR20 response. So Iguratimod can be added with tocilizumab also. So this is the largest study with Iguratimod and biologicals, but again, problem is it is a retrospective study. So patients should have biologicals at least for 6 months. They had moderate disease activity. So DAS28 should be more than 2.6 or less than 0.1, or the presence of synovitis with power Doppler score of 2 in at least one of the 28 joints. So these were the baseline characteristics. 75% of the patients were on methotrexate. So on other DMARDs were like sulfasalazine, busilamine, tacrolimus. Then the average duration of biological treatment was around 2 years. So they had 52 patients. Around 26 patients were on some kind of TNF. Other biologics were tocilizumab and abatacept. So DAS28 mean was 3.45. Patients has around 4 swollen joint and 3 tender joints. And total gray score was 14 and power Doppler score was around 9. So you can see that DAS28 score, it was at baseline around 3.4 and it came down to around 2.8 at 6 months. Then around 60% of the patients had moderate disease activity at baseline versus 40% in remission or low disease activity. At 6 months, actually this ratio reversed. 60% were in low disease activity or in remission, and 40% still had moderate disease activity. Then ultrasound score also, total gray skull score or power Doppler score reduced in the use of Iguratimod along with biologics. Can Iguratimod be used in chronic renal failure? So one mistake is there with 21 patients who were on the DMARDs but still had active rheumatoid arthritis. Patient had significantly improved DAS28 and the worsening of EGFR was not seen with Iguratimod. So it can be used in chronic renal failure, but the number is small. Then can Iguratimod be used in some comorbid illness? So they had 39 patients with neoplasm, 38 with latent tuberculosis infection, 46 with underlying pulmonary disease. Among these, 30 had interstitial pneumonia, and 28 patients had estimated EGFR of 60 mmHg. You can see that there was no statistical significance in adverse events in terms of latent tuberculosis infections or neoplasms or underlying pulmonary disease or chronic kidney disease. So apart from rheumatoid arthritis, is Iguratimod tried in other diseases? We have 2 small observational studies in ankylosing spondylitis, 30 patients or so in this group. So it was found to be effective with or without NSAIDs. Then trials are going on for lupus nephritis, IgG4-related disease, kidney transplantation, or Sjogren's syndrome. So these were the studies. What do guidelines say? So Iguratimod is already approved for treatment of rheumatoid arthritis in China and Japan. So one, the Japan College of Rheumatology guidelines say, so first line should be always methotrexate. If target cannot be reached at 3 to 6 months, then Iguratimod can be used along with other DMARDs like sulfasalazine or tacrolimus. Then what the APLAR guidelines say? So again, first line should be always methotrexate. If the patient cannot tolerate methotrexate, then they should receive leflunomide or sulfasalazine as first line treatment. Hydroxychloroquine, Iguratimod, busulfamine, cyclosporine, etc. can also be considered. So this is the APLAR guideline. They mention Iguratimod. Does Euler guidelines mention anything about Iguratimod? Yes. They say that, again, methotrexate should be always the first choice. If the patient cannot tolerate methotrexate, then we can choose leflunomide or sulfasalazine. So they mentioned that in some countries, especially in Asia, and agents like busulfamine or Iguratimod have been approved for RA, but these drugs were not considered here, given the insufficient data in other regions. So to conclude, Iguratimod have an effective effect in patients' indicative response to methotrexate and biological DMARDs. Iguratimod is well tolerated even in comorbid conditions. As per APLAR JCR guidelines, patients who cannot tolerate methotrexate or unresponsive to methotrexate, Iguratimod may be considered. But I must say, role of Iguratimod is still to be well established beyond few countries, and we need robust data. Thank you.
Thank you, Pradeep. Excellent presentation. So we had some more data on specific situations where Iguratimod can be used in comorbidities, in some other indications which are still exploratory. We need more data on lupus nephritis and syndromes like Z4 and Sjogren's. One thing that seems to be coming out is that for our country, countries like us, definitely it seems to be a sort of an add-on to the conventional drugs before trying out costly drugs like biologics and those kind of things. So with that, now we come to the last talk. We've had some questions. I hope for some more. Some of the questions are really very good, and I hope that our participants, our panelists, will answer them and satisfy all the questioners. Dr. Professor Malavia, and I don't think anybody needs introduction. That Professor Malavia needs any introduction. He is easily the father of rheumatology of India, and has been head of the clinical immunology at AIIMS long back, and then has been now practicing. He is our e-teacher as well. So only today morning when Professor Malavia was saying that I'm fine in the COVID times, I said, sir, we know you're fine by your emails, because every day we get teaching emails from him, all of us. So he's a sort of a teacher's teacher. We're very proud of him, of sir, and he still is perhaps the most avid reader out of all of us. I think all of us will easily accept that, and that is something to learn. The curiosity has always been there. Even drugs like Iguratimod, he would have, you will see that he is easily the best read amongst all of us. So sir, management of rheumatoid with Iguratimod, he tell us about the dose, duration, and those kind of things. And then at the end now of this talk, we'll have the question answer sessions. Sir, please.
Thank you, Sapan, for that introduction. Very flattering. Feels good. I would like to thank IPCA also for inviting me to give this talk. Hello, everyone who has joined us virtually on this webinar. Although the title is Management of RA with Iguratimod, difficult to pronounce, a tongue twister. My talk will be very brief because most of it has been covered by the excellent talks of the previous speakers. The first treatment of active rheumatoid arthritis as an add-on therapy, right away I say that till today, despite the availability of biologicals and oral synthetic small molecules, methotrexate still remains the anchor drug for the treatment of rheumatoid arthritis. And this has to be realized before discarding methotrexate. You try all possible tricks how to continue with that. And I will be mentioning a few small tricks how to make the patient tolerate methotrexate. Iguratimod is an add-on drug, basically, which has been tried extensively, but only in a few countries. And that is a major drawback of this drug, that its efficacy in other racial groups and other geographical areas is not well studied. And it is somewhat like MMF. And if you have seen the efficacy of MMF in USA between the African Americans versus whites is quite different. And this is how we are slightly concerned, and I think all the speakers have mentioned this concern, that this drug will need a little more trial, a number of more trials in different population groups, especially if we are in India. How does it behave among Indians? And that work needs to be done. For the treatment of active rheumatoid arthritis, add-on drug, who are inadequately responding to methotrexate, who are intolerant to methotrexate, and I have a lot to say about that. Honestly, intolerance to methotrexate could be 100%, but if you use the trick I use, the tolerance is near 100%. Who are inadequately responding to biological DMARDs. Even there, it can be used as an add-on therapy. The dose and administration, the dose is 25 milligram per day. In the beginning, you go slowly, build it up because it has certain adverse effects, and especially being an add-on drug, you know, methotrexate is the background drug which will be going on in most of the cases. So when you add this, the possibility of liver functions going a little off will be there. And so you watch that carefully. And after about 4 weeks, you add the full dose to 50 milligrams per day. And that has to be remembered. Usually, it's not permitted to exceed 50 milligram dose as per the studies conducted in Japan and China. Whether it is different in other races, again, needs to be established. Euler has said very easily, whenever you start a treatment or change a treatment, you must wait for 3 months for 50% improvement. That's a standard. And at the end of 6 months, they should achieve remission. If this has not happened, and you can then say inadequate response. So time to show benefit in this case, efficacy usually observed by 16 weeks. So it is slightly later. And if we stick to 3 months response, 50% improvement, it may not achieve that. It takes a little longer in the treatment. It is therefore recommended to continue it for up to 16 weeks. And that's the difference between other drugs that we use, where we say that 50% improvement is to be seen at the end of 3 months. And if that is achieved, we are almost certain that at the end of 6 months, the patient will be in remission. Not in this case, and they say use it a little longer before you say not achieved 50%. Considering the characteristics of Iguratimod and the disease, just let me carefully, clinical observation should be made during the treatment period, and administration should not be continued aimlessly. That means if at the end of 16 weeks, you are not achieving anything, there is no use, no meaning in continuing it further. That is what it means. Baseline prior to treatment with Iguratimod, what you should do is the usual. that we do in most of the, when we start most of the DMARDs. Blood tests, CBC, TLC, DLC, platelets. Renal functions, of course, the EGFR has to be above 60 to be considered normal. And if it is low, at least in methotrexate, we will start reducing the dose. But in this case, the speakers have mentioned that probably it is much safer and can be given even with some degree of renal compromise. But we will be doing, of course, the renal function test and the liver function test. During treatment, bi-weekly, once in 2 weeks in the first 2 months, which means it's a newer compound. We're not very sure how will it behave in our population. So, I mean, generally we don't do that early. We take 3 months, 6 months. Once the therapy is established, we will repeat the test only after 3 months. And after a few years, we take it only once in 6 months. But here, being a new drug, every 2 weeks, it is important for the first 2 months to be sure that we are not seeing any unusual adverse effects. During the treatment, patients should undergo these tests periodically. And if there is decrease in WBC, RBC, I mean, I will replace RBC with hemoglobin because RBC, platelets, Iguratimod should be discontinued if any abnormality is seen in CBC. Renal function tests, of course, we just learned that it is not that bad for renal, but we will definitely follow the creatinine clearance. LFT, elevation to 100 international units or higher of AST, LT, it should be discontinued. We are much more sensitive to it because we give it with methotrexate, and we don't like methotrexate causing high liver enzymes. Definitely not more than 2.5 times. It comes to about that actually. And then we have to be careful or stop and discontinue it for the time being till LFT improves. Chest radiography for interstitial pneumonia in suspected. Now, you know, methotrexate does not cause interstitial pneumonia. It has been proven beyond doubt now. So when we talk of chest radiography, interstitial pneumonia, we are talking of the disease itself. Because more and more studies with sensitive imaging of the lungs is showing that actually some little degree of interstitial pneumonia occurs in almost all the patients of rheumatoid arthritis right from the beginning. And as I keep saying, a rheumatoid is a disease that starts in lungs and ends in lungs. It starts in lungs, then it migrates to the joints, but then ultimately goes back to the lung and kills the patient. So chest radiography may not show much because it is not that sensitive. But if you start doing high resolution CT, you will see even earliest of early RA has some degree of interstitial lung disease. And methotrexate controls it. The moment you start giving appropriate DMARDs, that interstitial lung disease of early rheumatoid disappears. Iguratimod contraindications, okay? Pregnant women, the usual. Patients with severe hepatic dysfunction because it has hepatic toxicity. Patients with peptic ulcer because it behaves like NSAIDs. You know, it's very interesting drug. On one side, it behaves like NSAIDs and controls pain very quickly. The speakers probably didn't emphasize that much as I will like to do. One of the beautiful things about this drug is the pain control. And because of that, you hardly ever need NSAID combination once you are using Iguratimod. It has that excellent action on controlling and suppressing the pain of arthritis. So it behaves like NSAIDs, and NSAIDs are bad for the stomach. So this action has to be kept in mind when you are treating the patient with peptic ulcer. Patient with history of hypersensitivity, that's a usual thing. It can be hypersensitivity can occur to anything, any drug that you use. A patient on warfarin therapy because it has some effect on clotting factors. Special populations, hepatic impairment, as mentioned, it increases the liver enzymes. So current and past history of hepatic dysfunction, one has to be careful. In such cases, it is better to avoid unless you follow the patient very closely. And the problem was very minimal. Contraindicated, of course, if the liver disease is more serious. In renal impairment, administration with caution, as was mentioned by the speaker, risk of adverse reaction may increase in some cases, but relatively safer if you compare it with methotrexate and renal disease. It is contraindicated due to problems in pregnancy. And nursing mothers should avoid it. Is present in the breast milk. Animal studies has reported that it is excreted in the milk. Therefore, in lactation, it has to be avoided. Special population, pediatric, the safety has not been established. Even in adults, we have to study in our population, and children, of course, have never been studied properly. So that will be one of the research agendas. In geriatric population, one of the presenters mentioned that somehow it is a better drug for older people and males. So in geriatric population, maybe it is a better drug to give. It should be administered to elderly adults while closely monitoring patient condition. Because adults do have a lot of comorbidities. Although in the lecture, it was mentioned that in most common comorbidities, Iguratimod does not make much problem. But in elderly, you always are cautious, and that's what is recommended here also. Important precautions. Interstitial pneumonia, caution should be exercised against the occurrence of pyrexia, cough, dyspnea while on treatment with Iguratimod. This is mentioned. I would like to know from other speakers also, if they can answer. Is it due to hypersensitivity pneumonitis type of reaction, which is the rarest of rare methotrexate toxicity also? Or is it just because it causes some increase in infection, so there could be some increase in chest infection as well? That's why the caution is being given. I was not sure, I just wrote it down, but maybe it can be clarified. If any abnormalities are found, Iguratimod should be discontinued. Of course, you don't persist with the drug if you see some unusual things happening, including in the lungs. Low weight patients may have an increased incidence of adverse reactions. No safety studies are available, so it is just mentioned as a general caution. If abnormal findings are observed, it should be discontinued, which is a common sense recommendation. A drug interaction with warfarin, I have already mentioned. Be careful. With NSAIDs, I don't think you need to give NSAID in patients who are prescribed this drug, Iguratimod, because it does have NSAID type effect. But be cautious if you give it. I tell you something very interesting. I don't remember writing NSAIDs in any of my patients with rheumatoid arthritis since the year 2000. Because my teaching is very simple. You are treating the patient with rheumatoid and patient has pain. You question yourself, why does the patient have pain? You are controlling the disease, treat to target. If the pain is there, maybe disease activity has not been fully controlled. So instead of giving NSAID, why not adjust the doses, either increase or add DMARDs to control the disease to the full extent? Why give an NSAID, which is a toxic agent? That's the way I look at it. And honestly, I have not used NSAIDs since the year 2000 in my patients with rheumatoid arthritis. I don't see the need. The second possibility could be you are giving full DMARDs. The patient still has pain. That could be due to damage. Damage-related issues, immediately call your soft tissue surgeons and orthopedic surgeons. Can they see whether some minor, small operation here and there can relieve that pain instead of jacking up or adding NSAID, which is harmful, does not combine well with any of the DMARDs. In fact, when you combine NSAID with methotrexate and then see the liver toxicity. And then methotrexate is blamed, unfortunately. So don't combine NSAID with methotrexate. And in general, why give NSAID in rheumatoid? Check whether you are controlling the disease activity. Check whether the pain is due to damage caused by rheumatoid, which will not be relieved by DMARDs. You may need help of your surgeon colleagues. Phenobarbital plasma concentration may decrease, so be careful. In case of a patient with epilepsy or something, you cannot give it, or be careful. Hepatic dysfunction, pancytopenia. Pancytopenia, of course, with all the DMARDs, almost all of them, this happens. And so when you add it as an add-on drug, you become doubly cautious and look for any kind of blood count abnormality. Peptic ulcer, I already mentioned. Interstitial lung disease, I mentioned. Infections such as sepsis and pyothorax. Yes, conventional DMARDs also cause some increase in infection. However, if you start reading the literature in great detail, and as long as methotrexate, anyone talks about it, I will like them to go through literature and show me a paper that methotrexate causes increased infection. Iguratimod may be causing it, but I think conventional synthetic DMARDs causing infection could be relatively uncommon. It is biologicals that we are concerned with, and to some extent JAK inhibitors. Whether Iguratimod also falls in that category, I'm not sure, but it mentioned here, be cautious. Anemia, gastritis, dyspepsia, vomiting, these are the common things that we mention about every new drug that comes. So it is just the same list being repeated. GI, GU, something like that. Conclusion, Iguratimod dose in the first 4 weeks will be 25 milligram, and then you can increase and make it BD after 4 weeks. The efficacy is usually observed, as I mentioned, not in 12 weeks, but you can go up to 16 weeks if you don't achieve what you wanted to achieve by 12 weeks. Contraindicated in pregnancy, breastfeed, pediatric patients. Hepatic is not that bad, but hepatic is bad. Renal, not that bad as a side effect. It is effective as a monotherapy, but usually we will be using it as an add-on drug. So novel synthetic DMARD for the first time used in India, and a lot of work needs to be done. Iguratimod approved only in Japan and China, recommended by APLAR guidelines that I don't know, we are still following EULAR. It's an add-on therapy as far as we are concerned. Efficacy is similar to methotrexate. Is it? I doubt it, but it is mentioned, so I will say, okay, it says so, but it needs to be proven. Methotrexate for me still remains the anchor drug. Efficacy is said to be non-inferior to the standard drugs. Onset of therapeutic action is slightly later than the other drugs. Established 3-year efficacy and long-term safety up to 1 year. Thank you so much.
Thank you, sir. That's a wonderful summary, which actually summarizes the entire sort of symposium. A great summary. We'll now move on to the question answer. There have been quite a few questions. I think Shashank might have to leave a little early. What I'll do is I'll put up the questions one after another to each of you. The first question is, before we move on to the Iguratimod, there was this one question by a gentleman on methotrexate, and I would like Professor Malavia to take up that question on whether methotrexate split dose, taking it thrice a week kind of thing is better than taking it once a week. Sir.
The answer is very straightforward. Please remember, methotrexate is recommended as a single dose once a week. If you split it into 3, the father of methotrexate, that is Joel Kramer, in his words, this is the best way to kill the patient. Because if you give repeatedly, you are hitting the cells that earlier first dose, the cells were not in the mitotic phase. They will come in the mitotic phase and become susceptible to methotrexate. They will die in the first exposure. Then you give it 2 days later. The cells which were surviving and keep the patient normal now enter the phase where they are susceptible to methotrexate. They will die. And now you are 1/3 down, 2/3 down in your white cells. And by the 3rd dose, you will be killing rest of the white cells. And so the patient will be completely devoid of any white cell and will die. So this is strongly contraindicated. Never do that. Give single dose methotrexate and not more or not less. Injection is the best way to achieve that. In the first 3 to 6 months, you always start with injectable, which is much better tolerated, better action, better absorption. Absorption problem is not there. Intolerance mostly through the GI is not there. So you start with that, give it once a week, never split it into 2 or 3 doses. That's the answer.
Yeah, so there is this relevant question which has just come, so I'll take it up now itself, whether if a patient is not tolerating 10 milligrams of methotrexate, would you add another drug or do you split the dose? How to, and especially, is it related to the weight? Because the gentleman seems to be asking the weight of the patient is about 65 kg.
No, I tell you, methotrexate is an adenosine releasing drug. It works through release of adenosine. First, it increases intracellularly the amount of adenosine, which then increases in extracellular space. And adenosine is the strongest anti-inflammatory, rather anti-immunoinflammatory drug known to human being. And that is what methotrexate is doing. So at the low dose, that is up to 30 milligram weekly, it is not cytotoxic to that extent, and it releases adenosine. So once adenosine is released, everyone will get some or the other problem because adenosine receptors are present in the central nervous system. Adenosine goes there and sticks to these adenosine receptors on central nervous system. That causes nausea, vomiting, diarrhea, bloating, aversion, anticipatory aversion to methotrexate. Oh, I don't take Dr. Malvia's name. I get vomiting because he gives methotrexate. Don't tell me about that clinic where he sits, because the moment I remember, I try to think about that clinic, I start vomiting. These are called anticipatory side effect of methotrexate. Everyone gets it. Is nothing to do with any weight or anything. 100%. And when the patient goes in remission, by that time, % case of methotrexate develop intolerance. And that's the problem with methotrexate, which we resolved in the last 6 years. And obviously, we Indians, sorry to say that, believe in white skin. If something comes by them, everyone reads that. But if it comes from a brown skin like ours, we don't read each other's paper. I have written 3 major papers on how to offset this severe adverse effect by 6 cups of coffee and synchronized with the dose of methotrexate and adding one of the antiemetics along with it. Time doesn't permit, but if somebody wants, they can write to me on email. I'll send my papers, and I will tell you 2 cups of strong coffee in the morning, 2 cups of strong coffee 2 hours before the injection of methotrexate in the evening, and 2 strong cups of coffee next morning, along with antiemetic with each dose of coffee. And see, after 3 weeks, the patient will get rid of this adverse effect for life. It is unbelievable. They say, doctor, I have forgotten that I ever had that problem. And if you read my paper, which I keep on publishing in Clinical Rheumatology, 95% patients of mine are taking methotrexate beyond 5 years without any difficulty. Thank you.
Thank you, sir. So that's one of the ways to do it. And now we'll move on to Iguratimod. And I think Dr. Kerkar had to leave because he has some other session. Shana, you want to take up this? So there's this comment from Dr. Renu Saigal saying that there are probably genes which have been found out which might be make patients respond to Iguratimod or not. And therefore, we need more data before we actually said this is efficacious drug. I think that's well taken, Dr. Renu Saigal. I'll ask Shenoy the question on the biomarker. If there is any biomarker which can, for example, since this is an IL-6 reducing drug, could IL-6 be one of the biomarkers and any biomarkers which for response to therapy for Iguratimod?
I have not come across data. IL-6 reduction has been shown, but whether higher IL-6 levels predict a better response, I have not come across any data, but maybe we should explore that.
Any other biomarker that you would suggest for this? Are you aware of any other biomarkers?
No, I am not aware of. It responds both seropositives. Pradeep can say something.
Yeah,
Pradeep,
actually, can I add? Actually, measuring these biomarkers like interleukin-6 or something like that. So even say anti-IL-6 like tocilizumab, even that has not any correlation with the blood levels of interleukin-6. So I think so. Finding of biomarker in rheumatoid arthritis is still an illusion. We are not there probably still there.
Yeah, I agree, because even IL-6, there are problems with the assays and also, as he said, so I don't think most of us rheumatologists are still not jumping into such biomarkers, even during COVID times. The next question again for you, Shenoy, specifically for your data was, if the patients who were on the DMARD, did you actually add Iguratimod to those patients, or did you substitute the DMARDs with Iguratimod, number one? And the other was regarding NSAIDs. I think Dr. Manish Bavalia from Rajkot has asked that if NSAIDs, did you reduce the NSAIDs during your study, or were they continued?
See, regarding first question, I don't use NSAIDs. As Malavya sir says, if you have to use NSAIDs in rheumatoid, you are not treating them properly. So I don't use NSAIDs except on SOS basis, a couple of them per month or maximum. So try to avoid NSAIDs. The answer for that is NSAIDs are not used. Second question, yes, most of the time I added on. And once they responded, I withdrew another DMARDs. So for some of them were on the methotrexate, sulfasalazine, chloroquine, and steroids. On top of that, I added on Iguratimod. And the patient responds and tolerates this better, maybe sulfasalazine was stopped at a later date. That's how I followed it.
So you also had added rather than substituting?
Added on. Most of them added on. Except, for example, if somebody has cytopenia, I think that is one of the major indications I think where Iguratimod fits in. Those patients who are methotrexate develop cytopenia, 3,000 count, 3,500 counts. The moment you stop methotrexate and start on Iguratimod, their counts picks up and they do remarkably better.
Okay. The next question, sir, probably Professor Malavi, I can take it up. It is one of his areas of interest as well. Is two questions regarding NSAIDs. One was, do you think that the anemia of Iguratimod is because of its mechanism of action being similar to NSAID and therefore blood loss, number one? And the second question, a very intelligent question from someone from Indore, is that how do you make out if the tender joint count reduction is actually due to NSAID effect or due to any DMARD effect for that matter, if NSAIDs are being continued? So these two questions.
Yeah, very good questions and very difficult questions to answer. What was the first one, sorry?
Blood anemia jo hai, is it because action being like nimesulide?
No, I haven't done any studies and I have not come across any study that has studied the blood loss in the intestine with Iguratimod. What I usually do, because my belief, not study, my belief is that most of the cases of anemia in India are due to iron deficiency. And a very simple way is Menzer's index. I keep on calculating Menzers, especially in Delhi because we have thalassemia so commonly because the Punjabi population is quite a bit, and they carry thalassemia genes. So if I do Menzers index, and if I find that Menzers is clearly showing iron deficiency, then I will start doing where is the blood loss. If they are not having excess menstrual periods, then I will do the fecal testing to see whether they are losing blood and there is any problem in the gut. So this is how I go about them. I have not done any study on Iguratimod, so I cannot answer your question about that directly. And the second question was?
The tender joint count reduction is if the patients are on NSAIDs, what do you make out?
Yeah, the same. There is no way that I know that this is because of NSAID effect or because of the DMARD effect. So I take it as such. It's part of the drug. The drug is working, so I am happy. But the question is very good, and I cannot answer it scientifically, both the answers.
Yeah, I think that's what sir says, that only if the drugs are off NSAID, you can actually make out if the effect is due to. But as sir said, that if overall there is a response, and yes, you want to say something?
Just the answer to that will be only by looking at the radiological progression. We should look at the ultrasound and group of patients. We should look at ultrasound, whether Doppler signals are coming down, or do a structural radiological progression over a couple of years. That only can answer that question really.
Yeah.
So that's another
difficult question.
Yeah. Dr. Pradeep, I hope Pradeep is still around. Pradeep, you're there? Pradeep Sharma? Pradeep, are you there?
He's not visible.
He's there. He's there.
Oh,
I think
okay.
He's there, but
you're muted, Pradeep. So you'll have to unmute yourself.
No, I think it's some connectivity issue.
Hello, Pradeep.
Yeah, can you? Yeah, actually, in between I lost my internet connection.
Okay.
Probably, and now I should be visible.
Yeah. Great.
So there are these couple of questions which you would want to take up for you. If you are combining DMARDs and Iguratimod, then would you have to monitor more the liver and the renal function? That's number one. The second question is that if the patient is already on, can you combine with drugs like hydroxychloroquine, leflunomide, and sulfasalazine also, not just methotrexate? Number two. And the third, you've already covered that, but with biologics, somebody has again asked if biologics can give or not. Pradeep.
So I'm sorry, one question was whether it can be combined with other DMARDs or not.
Yeah,
actually, there is one small study I quoted. They combined Iguratimod with methotrexate, hydroxychloroquine, sulfasalazine, and steroid. So adverse events were not that, they had around 24 patients. So adverse events were not there. There was not much. One patient had GI intolerance, one patient had some elevation of SGOT, some had edema. So yes, probably it can be combined, but as all the speakers sir also is mentioning that we don't have that large scale data with Iguratimod. But whatever small scale data is there, it can be combined with other DMARDs. And biological DMARDs, definitely yes, it can be combined with etanercept, it can be combined with tocilizumab, it can be combined with other anti-TNF or even abatacept also.
Yeah, so Pradeep has answered that you can give it with biologics, you can also combine with DMARDs, although there's not much data, but I think you can do that. And it's not actually needed to very frequently monitor, just as about you would with any other DMARDs, you monitor these patients. Shinoy, regarding the flare rates, someone has asked that, is there any real life data of the flare rates with Iguratimod on patients who have been intolerant to methotrexate? If on Iguratimod, there are any real life data on flare rates in these patients?
Real life data, what I find is those patients who are on methotrexate intolerance, but the moment the stopping methotrexate because of two reasons why I find advantage. One, Iguratimod does not cause that much of alopecia, which like methotrexate. And second, cytopenia. In these two reasons, the moment you have to switch from methotrexate to Iguratimod, I must have switched 20-30 patients, that's all. None of them have relapsed. They respond equally well like methotrexate, and the remission is maintained.
So flare rates seem to be lesser, as Professor Malaki said, it takes about 16 weeks to actually have to wait that much time. Yeah. There were two more questions. One was on if the patient is already on 7.5, 10 milligram methotrexate, and he or she is not able to tolerate a higher dose, would you add Iguratimod? I think yes. That question also been answered.
I may add coffee instead of anything else.
Oh yeah. So you first give coffee, and then if the patient is still not
and keep on going up to 20, 25, and the patient will be all right.
Yeah. It actually makes sense to go to the highest dose of one drug rather than add another.
And switch over to subcutaneous.
Yeah. So that's, and then another question regarding methotrexate plus sulfasalazine, if you can still add Iguratimod, and I think that's so that's also been taken up by Pradeep, that yes, you can have 3 DMARDs also in these patients. One question, I don't know if Professor Malavi wants to take it up, is on upfront. Do you recommend upfront combination methotrexate and Iguratimod in patients to sort of debug the inflammation?
Not till now. I have not tested it. I think we will have to wait for more data on the Indian population to become available to answer these questions. We are at present, at least I am just a practitioner. So I will do what the researchers will tell us by large scale trials. Then I will try. The answer in short, no, I have not tested that.
Okay, so that has been taken up. There are a few questions, very interesting questions on other diseases. And for example, there is this one on extra articular manifestations of rheumatoid arthritis, whether Iguratimod would have a role there, especially in disease like ILD. I don't know if Professor Malavi, with his interest in ILD, wants to take that up. If any role of Iguratimod in extra articular manifestations?
I always say ILD is part of rheumatoid activity. ILD occurs in those patients who for years are on suboptimal treatment. Therefore, their rheumatoid has never been controlled. They are the ones, plus in addition males, plus in addition smoker. This combination is the cause of ILD. So if you start early, if you treat to target, if you have a patient where you can ask the patient to stop smoking and happens to be a female, you are quite sure that she is not going to develop ILD. And if you treat strictly to treat to target, and in that scheme, if Iguratimod is necessary, you will add that to methotrexate, and I think that will control rather than increase ILD.
And regarding the other extra-articular manifestations, sir, I don't think there is enough data to show that.
I need information.
Yeah, we need information on that. So regarding other diseases, Sharma, you've covered that a bit, Pradeep. In lupus, for example, can it be sort of first line? Then someone is asked if it can be used in scleroderma. And you yourself postulated in spondyloarthritis, especially ankylosing spondylitis. And that was something that intrigued me also. I was looking at the latest papers on Iguratimod, and it seems to be working on macrophage migration inhibitor factor, and that's one of those implicated in SPA. Yeah, so maybe Sharma can speak, and then you can speak as well. Sharma, you want to take that up? Pradeep?
Yeah, actually, yeah. So it in the animal studies, it has shown that actually it reduces IL-17 more than methotrexate or leflunomide. So it should be a good candidate for spondyloarthropathies, but there are only actually very small observational studies with 30 patients each. And regarding other diseases like lupus nephritis or Sjogren's syndromes or IgG4 related disease, or even in kidney transplantation, there are trials, actually they are recruiting patients, but data is still to be out.
Shino, you wanted to add something?
Yeah, I have 10 patients, 7 or 8 patients, approximately 10 patients of spondyloarthropathy who have failed on sulfasalazine, and we plan to add etanercept or IL-17 inhibitors. Before HICM that I have tried on Iguratimod, and response appears to be very good. At least out of 8, 3 or 5 or 6 responded. And the CRP came down remarkably within 1 month and appears to be working.
Yeah, because that's what I think Nigel was working on, this particular cytokine and SPA, and it also intrigued me. And regarding lupus, I think there is also data on refractory lupus nephritis, about 7 or 8 patients published data. And I remember Dr. Damodaran was telling me almost 6 months back that it might work in lupus nephritis, and I think it's true. Somebody has also asked on AOSD, adult onset stills. Shino, if you want to take it up, because the IL-6 levels are raised. And another disease which you are the most experienced is COVID. Obviously, the question on COVID, if it can have a role in COVID.
No data yet. Maybe because of the all mechanistic action, yes, maybe all these things can be tried, but we don't have a data.
So we don't have data on AOSD or COVID, and just because the IL-6 are raised, we cannot really translate that into effect. Professor Malavia, sir, a question on tuberculosis, latent tuberculosis. Sir, is there?
Yes, of course I am.
Yeah, sir, on tuberculosis, if any special precautions to be taken in latent tuberculosis?
Absolutely not. This is a big problem. I don't know. I got a letter from one of the quite a well-established rheumatologist, that why are you not giving anti-tuberculous treatment to patients who are on methotrexate? I got so angry. I mean, you know, these are not immunosuppressive drugs. They are immunomodulators. They don't cause a flare of latent tuberculosis. So I will say that there is no question of not giving the patient because the patient has Monto's positivity. And I will never give them treatment for latent tuberculosis while I'm giving conventional synthetic DMARDs, and Iguratimod is one of them. So there, I think the TB or LTBI and its treatment question does not arise.
So that should not be a problem. I think there are just the rest of the questions. There is one on blood levels if they need to be done with methotrexate or Iguratimod. Anyone wants to take that up, Shenoy?
I don't think it is being done. I don't think there's no need of that. I don't think it is required.
Yeah,
only thing that we look at the liver function test and other stuff.
There was one question on seronegative RA. I think it's the same as seropositive. There's no difference between Iguratimod. And the last one, probably Professor Malavia can give us his wisdom on how long can we continue with Iguratimod in our patients.
Again, information not available. But if I take it, compare it with the other DMARDs, everything is lifetime in rheumatoid. Whether it is a CS DMARD, B DMARD, or DS DMARD, they are all lifetime. This is a lifetime disease. Of course, the dose may be modulated, but we need information. How do we taper off the dose? Or how do we reduce, etc.? We will need more information. But I will say long-term use.
Yeah. So long-term use should be okay. So can I have one line from each of you on where would you place Iguratimod as of today with the evidence that we have now? We can start with Professor Malavia and then Shana to summarize because I need to summarize. I'd rather have you summarize, all of you.
I tell you, when methotrexate starts failing, one starts wondering what to do. Patient doesn't have money for the biologics and for the JAKs. So usually we used to add leflunomide. I always said leflunomide plus methotrexate is like riding a tiger. This adverse effects, especially on liver and the blood, are so much and so often and so bad that I was never comfortable with that combination. So I would put methotrexate inadequate response where the patient cannot really go for the more expensive drugs. I think this is a wonderful new addition, and it will be saving those patients, and I'm happy about it.
Yes, Shina, your one line.
One line. Those patients who are unable to tolerate methotrexate because of cytopenias or a lot of alopecia, I think leflunomide is not a good choice there. That is the case I place Iguratimod. But we need more data on structural progression.
And Sharma?
Yeah, exactly. I want to actually what Seno is saying. I want the same thing. Actually, we need more data. Still, it is still to be established actually as a DMARDs because we don't have radiological data. We don't have long-term data.
So with that, I think we come to the end of the symposium. In summarizing, I'll just summarize it for everyone and then we'll call it a day. The summary is that we began with Akerkar talking about the mechanism, and I think it has pleiotropic effects. It's mainly an NF-kappa B inhibitor, but also acts on bone and cartilage and various inflammatory cytokines. We've also seen that it seems to be working on IL-17 and macrophage migration inhibiting factor, those kind of cytokines. The role of the drug, as Professor Malavia very rightly summarized, seems to be in methotrexate refractory patients, or who first you give methotrexate, and those who are intolerant, you try injectable methotrexate and those kind of things. If you still can't tolerate, there might be a role, rather than as Sheno and Dr. Sharma also said that adding leflunomide, which the combination might be, you might have to look for cytopenias more. So especially if you have the cytopenia kind of a thing with this combination, then you would rather give Iguratimod to these patients and see how they act. We can combine Iguratimod with other drugs also, with biologics also, as Dr. Pradeep Sharma said in his talk. Regarding its role as upfront, we are still not sure. In other diseases like lupus, scleroderma, we are still not sure. We need more data. Regarding other indications, also regarding the extra-articular manifestation, it seems to be safe in tuberculosis. That is something that came out. And lastly, I think one thing that does come out and striking from this particular symposium is what Shenoy has done. So I think all of us need to collate data. We give it to our patients. It's just that we don't document it. And I think one learning lesson, if there is one learning lesson, and I'm so sure Professor Malavi will agree, is that just document our data and with application of outcome measures and see how these patients are doing. That's good observational data from our own country to see if it's really working in our patients. That is the single most thing that we need to do. And maybe in the next symposium, when we have 6 months down the line or a year down the line, we have more data on Iguratimod, because since it is cheap, it is something that should be very useful to us. So I think with that, I must thank IPCA for this symposium. I must thank all the panelists, Professor Malavia, sir, especially for his wisdom, and all three speakers, panelists, Shenoy, Dr. Sharma. We had this north, east, west, south, perfect. And Shashank Akerkar, who's not there, for all their wisdom, especially regarding clinical experience. And with the reminder that we have these IRA webinars every last weekend of every month, which is something that all of us should attend. There's also this fellows retreat for those who are teachers, for their fellows. And you can write to me, the secretary, if you have any questions regarding the links. It's meant to be for fellows, the DMD fellows and the structured fellowship fellows on the third weekend of every month. So with that notification to all of you, reminder to all of you, I appeal to all of you to stay safe and healthy. Thank you. It was a good symposium and a very informative one. Thank you, all of you.
Thank you.
Thank you.
Thank you, everyone.
Thank you. Thank you.
Thank you.
Bye-bye.